national Canada, we have called DEC, Diabetes Education Centers. And typically when someone is diagnosed with prediabetes and or type 2 diabetes, they're then referred to a DEC to get information related to their new diagnosed condition. Typically the information that they're given is information related to diet and how to modify their diet and their meds. So the counseling is primarily focused on meds and diet. And little expertise exists within those desks, within that nursing base and diabetes educator base, on what really is the role of physical activity. And we know from a motivation perspective, just to tell people to become physically active is not enough, especially if they're not being prescribed physical activity or when they're having to make so many lifestyle choices. You can just tell me when to be quiet so that we can get him going.
I thought we were interrupting you.
Oh, no. Are you ready? I'm just thinking. Yeah. So just with a little bit of a background, when it comes to diabetes care, that we really need to make sure that physical activity plays a significant role in managing lifestyle. Before someone is diagnosed with diabetes, how long do you think they might be living with prediabetes? How long do you think they might have all of the risk factors and symptoms before they're actually, who wants to take a guess? Okay, so typically it's about 7 years. Of course, that's just the average, could be more, could be less, but that's a significant period of time. One of the greatest risk factors that is modifiable is obesity and managing your weight, and the role of cardiorespiratory fitness in helping these people with their overall weight loss and management.
If we don't have video, if we still have sound.
Are we good to go?
If you want to tell them
Is it this mic right here?
Yeah.
And do I just talk into it?
Yeah.
Okay, so welcome, Jonathan. We're just here at the conference. You can probably see us. We can certainly see, no, we don't see you right now, but we see your PowerPoint. So the audience is here and they're all ready to hear your presentation. Dr. Jonathan Fowles is an exercise physiologist whose work in the Center of Lifestyle Studies at Acadia University, specifically in this realm of his presentation, exercise program with chronic disease or disability.
Hello, I seem to have lost your video.
Do you want me to talk?
Jonathan, to go ahead.
Jonathan, you can just go ahead now.
Oh, okay. Sorry, I thought I had gotten lost there because I lost your video from the conference room there. So I'm good to go then? All right. Well, thank you very much. It's a pleasure to present this information to everybody today. This is a little bizarre because I thought I was there a second ago. Anyway, so I will be presenting on physical activity counseling and exercise prescription for individuals with diabetes. This is an extension of the work that we've been doing out in Nova Scotia for the last 3 years now through a Lawson Foundation-sponsored initiative to disseminate a physical activity and exercise toolkit to all of the diabetes centers in Nova Scotia, and is now disseminated to all the centers in the Atlantic region, so including New Brunswick, PEI, and Newfoundland. So here's some of the, I'll be sharing with you some of the learnings that we've had from doing this over the last 3 years. So today I'll be covering some learning objectives, why we need physical activity and exercise, and as was mentioned before, that this may be speaking to the converted a little bit in this room. but I hope to kind of frame physical activity messaging and as it relates to diabetes specifically with regards to the recent physical activity guidelines that have come out in 2011, as well as addressing challenges for physical activity counseling in routine practice with practical messages for individuals with diabetes, as well as some important points on exercise prescription. So to put things into context with regards to physical activity, we as a species, as humans, have always needed physical activity. Our gatherer ancestors for millions of years covered very large areas of land in order to gather food. On average, through historical records, 9 to 15 kilometers a day just in basic subsistence. And then our hunters ran and did vigorous activities for another 10 to 25 kilometers per week on average in persistent hunting. That carried for millions of years until, several thousand years ago, where stationary farming kind of took over. And the average stationary farmer did, 8 hours of moderate to vigorous physical activity per day, with very little time being sedentary, less than 4 hours spent sedentary. And this has been modeled basically in the Amish communities in southern Ontario, for example, where they average between 14 and 18,000 steps a day because they don't use basically modern innovations to do their farming. And interestingly enough, with very, very high levels of physical activity, they have very low levels of obesity, 0% for men and up to 9% for women. But on average, 4% of their population obese, whereas 1/3 of our population and 2/3 of our population being overweight or obese. Even today, in third world countries, 50% of women walk more than 5 kilometers each day for water. So you can see that as a species, we've needed physical activity and have had physical activity for hundreds and thousands of years. And so when we look at the new guidelines for older adults that were released by the Canadian Society for Exercise Physiology in January, where we're recommending as a minimum that people achieve 150 minutes of moderate to vigorous intensity aerobic physical activity per week, being 30 minutes a day, that's basically the minimum dose compared to what our bodies really need. It is also beneficial to add muscle and bone strengthening activities. And for older adults, those with poor mobility should perform physical activities to enhance balance and prevent falls. So these are for those that are at limits to do balance and strengthening activities specifically. The key thing here is that more physical activity provides greater health benefits. There really isn't a bottom end with regards to accumulating physical activity and its benefit on overall health, except at the very, very extreme ends. So if somebody actually did follow these physical activity guidelines, what would be the benefits? Well, the benefits are numerous. Reduce risk of death by 40 to 60%, risk of colon cancer by 60%, recurrent breast cancer by 50%, reduce incidence of coronary heart disease by 40%, and the list goes on. Reduce risk of stroke, and decrease depressive symptoms as effectively as Prozac or cognitive behavioral therapy. So one of the key things is when we talk about diabetes and exercise, that it's not just blood glucose monitoring, it's multifactorial, and that when we look at metabolic disease that has comorbidities of hypertension and heart disease and risk of stroke and comorbidities of depressive symptoms, exercise really is as close as you can get to a magic bullet with regards to a major healthcare intervention. When we look at the context of physical activity, we also have to look at the context of what is now an emerging science in sedentary behavior. We've for years put the onus on exercise, which is a very specific structured behavior, which only about 15% of the population actually does. Then it's been generalized to more physical activity in general terms, meaning active transportation, all these other things. But the emerging science really is on the amount that we're sedentary now. And so the new guidelines, and these are the Canadian Society for Exercise Physiology released the world's first evidence-based sedentary behavior guidelines for children and youth most recently in February. basically saying to limit screen time to no more than 2 hours per day, recreational screen time. And that's because we're seeing that our children and youth are spending approximately 9 hours a day sedentary and 6 hours a day in front of a TV or in front of a game screen or a YouTube video or whatever it might be. So limiting those kinds of things and limiting motorized transport is now what we're going to see with regards to physical activity guidelines. There's going to be sedentary behavior guidelines, physical activity guidelines, and also exercise behavior guidelines. What are the benefits of not being sedentary? Well, they're almost as strong, and they're a separate and independent risk factor than physical activity or exercise. So if you're not sedentary, meaning that you spend less than a quarter of your day sitting versus most of your day, there's a 50% lower all-cause mortality risk. And this is controlled for age, smoking level, and physical activity level. So it's an independent risk factor relative to your physical activity and exercise behavior. And that was a recent paper published. Interestingly enough, when we put it in the context of TV viewing, which is a yardstick for sedentary behavior, for each hour less of TV viewing, you can get an 11% reduction in all-cause mortality, 12% reduction in obesity, and a 7% reduction in the incidence of diabetes. So the guidelines, that's where they come from, to spend less than 2 hours a day in front of a screen in your recreational time. Obviously, occupationally, we do have to spend a lot of time in front of the screen, but I'll talk about that one in a second. So when we look at the actual levels of physical activity in Canada, it's interesting to note that by self-report, many Canadians feel that they are being moderate to vigorously active. Half of all Canadians report moderate to vigorous physical activity. However, when you actually objectively measure this, and this was done for the Canadian Health Measures Survey between 2007 and 2009 and recently reported in health reports, that only 1/3 actually achieve a target of 10,000 steps per day. When we actually look at the CDA and CSEP guidelines for physical activity of achieving 150 minutes per week, only 15% of our population objectively achieves that target by accelerometry. And if we put the standard as 30 minutes of moderate to vigorous physical activity per day and at least 10-minute bouts at a time, 5 out of 7 days, only 5% of our population would actually achieve that objective. So although many of us feel that we're being maybe more active than we are, when you put it in the context of how 100 years ago, we tended to do 8 to 10 hours of moderate to vigorous physical activity per day, and now only 5% of us can do 30 minutes of moderate to vigorous physical activity per day. It's quite alarming. So there's the average of 24 minutes. But the big one is the 10 hours a day of sedentary time that we now spend. And this data has basically been supported by a very recent study just published in online in PLOS ONE by Church et al., which is Stephen Blair's group out of the Aerobics Lifestyle Institute down in Texas, basically showing that over the last 50 years, or last 40, well, they did from 1960, so 50 years, that there's been a decline in occupational energy expenditure. This is true for both men and women due to a decrease in manufacturing jobs and physical agricultural jobs, and an increase in service jobs and desk jobs. And they actually took the NHANES data, which is the national database for height and weight records and diet and physical activity, and they looked at objectively measured, which is the NHANES data in the white bars here, objectively measured obesity rate increases since 1960. And when you plot that relative to the decline in occupational energy expenditure alone, there's a very strong relationship in both men and women to these increased rates of obesity. So, and they actually also say in this paper that there's very little evidence to say that there has been a decline or an increase in average levels of diet. So when you look at the obesity epidemic that we're facing, and which then leads into the diabetes epidemic, that total physical activity has dropped continuously over the past 40 years, basically due to modern innovation. And that diet initially dropped till about the mid-'80s, and then it kind of plateaued, so that this difference now is only maybe 100 calories a day at the most, But this big difference with reductions of total physical activity continuing to drop. Some reports show that our total physical activity levels have dropped almost 400 calories a day since 1960s, 1970. And so this results in this very large weight gain that we see that relates to the diabetes population, low socioeconomic status, these kinds of things where, the challenges to be active are even greater. So when we look at what we're facing now with the diabetes epidemic, this quote from Albert Einstein, the significant problems we face cannot be solved at the same level of thinking we were at when we created them, is quite apropos in the sense that modern innovation has given us time-saving devices, quote unquote, but it has done it at the expense of our health, because now we spend a lot of our time sedentary in front of a TV or in front of a screen. So the time that we save, we now use in sedentary pursuits, and therefore we have to look at what these things actually do. Escalators, elevators, the car, TVs, and computers are really are decrements to our health, and we have to think of it differently now. And we also have to think consciously about physical activity, because it wasn't on our voluntary conscious radar screen 100 years ago because we just did it in our daily lives. But now we have to consciously think about it and include it in our day because it has been engineered out of everything that we do. So why do we need physical activity and exercise? Well, because it is a basic physiological need, like breathing, eating, and sleeping, that modern innovation has created this imbalance or disease. And that being healthy in today's society is technically abnormal behavior. This picture here is not a value-based judgment on anybody with diabetes or elsewise. It's just a statement of 2/3 of our population is now overweight or obese because of the engineered society, obesogenic society that we now live in, and that you have to swim up current or against the current and go out of your way consciously to plan to be active and plan to eat healthy in order to be healthy. And so it's very challenging for most. So when we look at 2/3 of Canadian adults are overweight or obese, and now 25% of our Canadian youth are overweight and obese, and this is anywhere between a 300% and 500% increase since 1981. So this is 40 years and a 400% increase in overweight and obesity. And so when we look at its relationship to diabetes, well, we see diabetes down here at the bottom, but the very, very first step of the diabetes progression is this energy imbalance. And that it is true that there are certain genetics that predispose people to obesity and diabetes, but these are that, meaning that about 50% of your basal physical activity level or your voluntary physical activity level can be attributed to genetics. However, at any level of genetics, more physical activity or balancing your physical activity to energy intake will not result in a progression. And so the other point being that in the last 40 years, obesity, diabetes rates have increased 400 to 600%, whereas our genetics have not changed at all. Basically, our genetics have not changed, or have changed 0%. So the environment is factoring in this very, very first step quite dramatically. That energy imbalance then leads to abnormal muscle and adipose biology, where free fatty acids basically collect into our bloodstream, which then creates excess adipose tissue and insulin resistance, which then leads to dyslipidemia and dysglycemia, which then progresses with diabetes and the comorbidities of hypertension, hypercholesterolemia, and metabolic syndrome. This then leads to increased heart disease, cardiovascular disease, and higher levels of mortality. But at every single step of this cascade, and in every single progressive instant, physical inactivity will accelerate the cascade, and physical inactivity or physical activity will attenuate or even regress. And there's very good evidence now that if you maintain high levels of physical activity or exercise with appropriate diet, that you can basically become asymptomatic, even though you might have had type 2 diabetes as a diagnosis. This is supported by lots of very, very high-level studies, very strong evidence from randomized controlled trials from all corners of the globe, all 6 continents, and very large studies. This one here is just a selection from 8,000 non-diabetic men that followed up for 6 years that showed that the objective measure of physical activity, which is cardiorespiratory fitness, meaning that the more physically active you are, the higher your fitness will be, that there's basically a 20 times difference in diabetes rates between somebody who is low fitness and impaired fasting glucose or pre-diabetic, meaning most likely obese, to somebody who is normal glycemic and very high fitness level. But you can see that in both the impaired fasting glucose and normal glycemic levels, there's a 5 times or a 5-fold difference in risk for somebody at low fitness to somebody at higher fitness. So, and this is just one study that shows this quite clearly, but there are numerous other studies that have done the same thing. There's been these large RCTs with the diabetes prevention trials that when actually people have impaired fasting glucose and you intervene with appropriate lifestyle, being diet and exercise, that you can reduce the conversion to diabetes by at least 50%. And in some studies it's higher. And the key thing in all of these studies is that at higher risk levels and greater age, the risk reduction is even greater. So for example, the commonly quoted studies are the DPP and the DPS, where the average risk reduction was 58 and 60%. But if you look at the quartiles there, the older adults, the risk reduction is 70 to 80% in the older ages above 65 years old. So that underscores the importance of appropriate lifestyle for older adults specifically. So the CDA in the 2008 clinical practice guidelines recommends 150 minutes of moderate to vigorous intensity aerobic exercise per week. And again, this is different than the generalized physical activity recommendations for the Canadian population now, because it contextualizes that exercise is necessary to correct the progression of disease, that you need things of sufficient intensity and of sufficient duration and frequency in order to correct the problem, that just accumulating physical activity is enough to prevent the problem in the first place, but once you get it, you need exercise as medicine to correct the problem. So you'll see resistance exercise 3 times per week, in addition to aerobic exercise, is also required, which is again similar to the generalized guidelines for CDA. It looks like I might have lost my video there or something. I'm not quite sure what's going on. Now going through a progression of Handycam and various other things. I'm going to turn my video off and on again and see if that works. Oh, now I'm seeing the classroom. Everybody wave. How's everybody doing? Oh, good. We're all listening. I can't see mine now for some reason. But anyway, I'll continue. One thing that we've done out here in the Atlantic region is we've surveyed individuals with diabetes and actually looked at who is meeting the CDA guidelines. And as you'll see, that up to 40% of them report moderate physical activity at least 3 times a week, which is slightly less again than the Canadian population, which is typically been reported in other studies. Anywhere between 23 to 40% report moderate physical activity for different diabetes populations. But the key thing is that according to the CDA guidelines, who is meeting the aerobic exercise guidelines of a minimum threshold intensity for a minimum duration, is less than 10%, and the same thing for the resistance exercise. And when we see who is really meeting the full CDA guidelines of both aerobic and resistance, it's really only 2.4% of the population. So that means that we do need to do more with regards to recommending and promoting physical activity and exercise. This Glassbergen cartoon here is quite fitting. What fits your busy schedule better, exercising 30 minutes a day or being dead 24 hours a day? Of course, I'd never say that to somebody directly, but it does kind of paint a picture or a point that, we in our society, being sedentary almost 10 hours a day now, we are paying for it with our health, and we will be the first cohort of people that will have our life expectancy shorter than the previous generation. We'll be the first generation in history that will have a shorter life expectancy than the ones that preceded it. So we can choose to exercise or not. The one thing that that previous slide also shows is that the best exercise program in the world doesn't work if nobody does it. There's reams of very high-level evidence that says that exercise is very potent, not only to prevent disease, but also to correct it and manage it. But if only 2.4% of our diabetes population is actually doing it, then that can be a challenge as well. So the number one practical message that we have for diabetes educators, for primary health care, is that regardless of the starting point, a regular pattern of activity should be advice given repeatedly by all members of the healthcare team. And that there's strong evidence to this link. However, physical activity is often a message that's lost in the time constraints of a busy medical visit. We see in diabetes centers that, there's things that you have to cover, like, insulin management or meds and diet and foot care and, blood pressure and all these things that are ingrained within diabetes care, and the physical activity message is either absent, and according to our data, only about 1/3 of diabetes educators talk about physical activity regularly. Only about 15% of primary care physicians talk about physical activity or provide a written exercise prescription or a direct recommendation for exercise. And so what that can convey to the participants is that maybe it's not important, and moving on. So the other thing is that I think people may not be aware of the potency of its effects, specifically with regards to diabetes, and that many people associate exercise or physical activity with weight loss, and therefore that the effects of exercising are in the distant future. That, if I can only lose 10 pounds 6 months from now, well, then that might help with my diabetes. But the actual mechanisms for exercise are also immediate, and that's important to understand as well, that glucose uptake, insulin action, all these things are also very important considerations. So when we look at diabetes, and we know that the situation of diabetes is a impairment in insulin action or an impairment in your response to the available insulin that you do have. In type 2 diabetes, that the signaling cascade to insulin becomes dysfunctional. However, and this, that there is basically a parallel system to activate glucose transporters right here to the membrane to transport more glucose into the cell. And when we are not physically active, then the insulin pathway is overutilized. But when we are active, it tends to unload this pathway. And so therefore we know that exercise can also do this exact same mechanism at any time. And so the role of exercise really is that either at low levels, low intensity exercise, or high levels of exercise, that for both lean as well as type 2 diabetes patients, the ability to transport glucose is still there using the exercise cascade. So the other thing is that if we look at insulin sensitivity, that part of it is glucose transport, but the other part is actually sensitizing the transporter proteins for the insulin that is also available. That for a type 2 diabetes patient, the insulin sensitivity is quite low, but with exercise it restores or normalizes almost completely. We see this that actually if we take diabetes patients and actually follow the CDA guidelines for 30 minutes of exercise, either aerobic walking on a treadmill or doing 30 minutes of resistance band training, which is low to moderate intensity, it's about 3 METs, that within 30 minutes you can reduce blood glucose levels by 3.5 millimolar in aerobic, And the effects for resistance band training kind of progress a little bit more because the intensity on the muscle is a little bit higher, so it continues to unload glucose from the blood into the muscle with resistance training. But again, a 3.5 millimolar reduction in blood glucose from 30 minutes of exercise. So the effects are quite immediate and available at any time, any place, anywhere for anybody with type 2 diabetes. That if they want to go for a 15-minute walk, you can get half the effect, and do it again multiple times per day, and you'd even be better off. But the effects are immediate, even far before you lose weight, and so that's a major benefit. So the benefits of exercise, or the evidence for diabetes, is quite dramatic in that either aerobic or resistance exercise has equal effects. That on average, after a period of exercise, of aerobic training or resistance training, we have an average reduction in A1C by about 0.7%, and the range is between 0.5% and 1% for either of these, and that the beneficial effects are independent of weight loss. There are greater effects if you also do lose weight, and that's partly because you also increase your relative fitness that way, but also the inflammation cascades and things are reduced when you lose weight. But there are specific dose-response effects from doing the exercise right now. So 150 minutes a week, you get a direct enhancement of insulin sensitivity. Now, brisk walking is easy to do, and it is the more popular form of exercise. However, resistance training, if you do 2 to 3 sessions per week, is 60 to 90 minutes. So you can even see there that half the amount of time of resistance training, you get the same effect because the actual intensity on the muscle is higher, and the activation in the muscle is the key thing. The other important thing, especially as we age, is that it helps preserve an active muscle mass. One of the reasons why diabetes rates increase exponentially with age is because our lean muscle mass decreases exponentially with age. And so resistance training helps preserve an active muscle mass where 80 to 90% of blood glucose is actually deposited. It's not in liver, that's only 10%. It's in active muscle. And the more we activate muscles, the more we clear blood glucose, and we have better glucose management. The other thing is that it's also a good alternative for those with mobility problems. We see that about 1/3 of diabetes patients actually can't go for a walk, even though many of the recommendations say go for a walk, because of foot problems, orthopedic issues with knee, hip pain, ankle pain, that kind of thing. So doing a seated resistance training program is actually a very, very good alternative for those people, so that you can still get the benefits of exercise without having to have those. So we also see, and this is a randomized controlled trial by Ron Siegel out of his work in Ottawa and Calgary, that when we combine both resistance and aerobic exercise studies, and this one was done over 6 months, that we see a combined effect that's double the effect of either intervention alone. So either of these is 3 days a week. When you combine them and do it 6 days a week, well, you get double the effects. And that's basically, again, the dose-response effect. The more you do, the better off you are. So the practical message for number 2 is that physical activity and exercise can actually give and empower patients with control, that it's available to them at any time, anywhere, and it has a direct effect to increase glucose uptake and improve insulin sensitivity. So instead of disempowering the patient with medication, meaning that if I'm sick, I take medicine and then I'm okay, versus empowering the patient with something that gives them control over their situation, and physical activity being a healthy behavior that can give that person control over their situation. The benefits occur in a dose-response manner, that any physical activity is good, and we see that with the sedentary behavior guidelines, that just getting moving and not being sedentary is a step in the right direction. However, doing structured exercise according to the CDA guidelines at a minimum of 4 METs, which isn't a lot, it's a brisk walk, you get more bang for your buck and immediate reductions in blood glucose, etc. The other thing is that exercise and physical activity can reduce comorbidities, which no medicines can do. If you take metformin, it reduces your blood glucose, but it doesn't have any effect on your triglyceride levels or your blood pressure or anything like that. Whereas, or you take a statin to reduce your LDL and affect your HDL, but it has very limited effect on, blood glucose regulation, whereas exercise has global effects. Now, with all those wonderful things and the effects specifically for diabetes, this is, again, an important slide that opportunity is missed by most people because it's dressed in overalls and looks like work, meaning that many people or healthcare providers say that, well, my individual's diabetes doesn't want to do exercise. Well, there's different data to that context. We did a study out here of surveying patients in different capital health board districts, over 2,200 patients, and asked them what would be the one thing that they would want to do to improve their physical health if they could improve the most important thing. And 60% of them, across all of the 6 different health districts, chose physical activity or exercise. The second highest one was 13%, which was diet. So the awareness is out there that physical activity is important, but many people just don't know how to do it and what is the next step. We also see this played out within our relationship between the diabetes educators and the clients. And that one thing that we found is that the diabetes educators identified that a lack of interest by the client was a major barrier, or 1/3 that they faced in counseling on physical activity, and that they perceived their client attitudes to be low. However, when we actually survey the clients, they perceive their own client or confidence, so this is the client's confidence in themselves, to be quite higher than what the diabetes educator evaluates it, and also they have quite a bit of confidence in the diabetes educator themselves to tell them what to do, whereas the diabetes educator might not have as much confidence themselves. So that's where we came from with our diabetes toolkit in helping to educate the diabetes educators on physical activity and appropriate messaging. And that's where, what you think becomes what you say, and that if you don't have confidence in the message, you tend not to talk about it. And only 1/3 of them were talking about it in counseling sessions. And that can translate to the patient that maybe it's a low priority, or maybe you don't actually need to take care of physical activity. So our first message being, physical activity, one of the first 3 topics you cover in every visit, is very, very important. The other last couple points here is that the key one is to meet the patient where they are. That last data shows that many patients are aware of physical activity can be good for them, but they may not know how good it can be, both the acute effects as well as the long-term effects. And they need to value what physical activity can do for them. So many will say, well, I'm being active so I can lose weight. But it's a good step to then take it from an external motivating factor, such as the scale, to an intrinsic motivating factor, such as, why do you want to lose weight? Do you want to feel better? Do you want to play with your grandkids? Do you want to be not as tired at the end of the day? And let that be the motivator to help you move forward. And then once you've then been able to bridge or leverage some motivation by getting to a value-based motivation around physical activity, then you need to bridge the awareness-action gap by following up with a specific prescription that has how-to information, because a lot of people are aware, but they don't know how to take the step. So in that context, we have developed, again, with the Canadian Diabetes Association, which will now be releasing a prescription pad to all primary care physicians in Canada, actually this week, a graded exercise prescription that should be relevant to the different, levels of physical activity interventions that would be possible. The first step is, again, saying this statement: regular physical activity is important for health and reducing risk of disease. As your healthcare provider, I recommend you meet the following prescription. So number 1, if they're inactive and not really ready to move forward with a regimented physical activity program, well, at least limit your screen time and reduce your sedentary behavior, because that's a step in the right direction. If you are including some physical activity or reducing sedentary behavior, or you're ready to begin a regular physical activity program, we'll start small with 3 to 4 days a week, 10 to 15 minutes per session, and build on success, as opposed to saying you need to do 2.5 hours of exercise, and then that person becomes very demotivated and doesn't do it because they don't want, they don't see that as an achievable goal. The next one is maybe starting with some light introductory resistance activity, such as, TheraBand or introductory weight training, something like that. Even, I would say yoga or Tai Chi is kind of an introductory to an muscle engaging activity that would be a stepping stone to more formal resistance training where real benefits are. And then these are really where our CDA guidelines are, which is doing aerobic exercise for at least 30 minutes at a moderate intensity at least 5 days a week. And then if they're doing that but not doing resistance training, well, maybe your number 5 exercise prescription is to do the resistance exercise to get that added benefit and the more bang for your buck. The key one is to pick one and to give them a very specific direction and some how-to information on that. We have developed with the Diabetes and Exercise Toolkit out here in Atlantic Canada some brochures and some how-to information, which is now going to be adopted by the Canadian Diabetes Association and will be available for all diabetes care providers in the country beginning in the fall. And these brochures and this toolkit basically provides more follow-up information in that regard. What are some primary barriers that patients face? Well, the generalized barriers are time, motivation, know-how. Those are ones that we all face, and everybody in today's society has a challenge of time. And am I motivated when I have the time? And do I know what to do at that time? So one way to help leverage motivation and empathy is to actually, say that to the person in front of you and say, you know what, we're all challenged with these things, but it's really important for our health to make the time if you feel that, health is important to you. Now, the other thing that people with diabetes also have are these disease-dependent barriers, such as, considerations for hypoglycemia, hyperglycemia, or arthritis, or comorbidities for cardiovascular disease. And to that, there's some fear associated with progressing, and maybe some of you as fitness instructors have faced this, but the evidence on this is actually pretty strong as well, that the risk of exercise and the complications to exercise is actually very low. That the complication rate for aerobic exercise is 1 in 100,000 hours. Now, if this was a drug, we wouldn't even have to report it, because anything less than 1% complication rate don't have to be reported. And, a resistance exercise injury rate of less than 1 per 10,000 hours, like it's actually higher for walking, of 3.2 musculoskeletal injuries per 10,000 hours of walking, again, would even be below the 1% threshold, so we wouldn't even have to report it if it was a drug trial. But there is fear out there that if I do something active, I'm going to drop dead of a heart attack, which isn't really true. There are certain people that may have higher risk, and so if people are currently symptomatic with chest pain or peripheral vascular disease, leg pain, that kind of thing, well, then they should be screened more thoroughly. But for the asymptomatic individual that does have, diabetes but is wanting to move forward, starting with low to moderate physical activity is safe and is actually reduces their risk of complications. So that is a key message to, again, impart to your patients. The last couple things I'm going to leave here and then open it up for questions is that, so addressing comorbidities is important, that the disease itself does create challenges for physical activity. Obesity is a challenge to be active, carrying around extra weight, orthopedic problems, medications, and that it does reduce exercise tolerance. That creates discomfort. Many people with diabetes report that it's uncomfortable to exercise, but that is one thing that's different than if it's pain. Well, that's one thing that might stop activity, but if it's discomfort, it's a challenge to your body that is actually a good thing, and that increases your body's strength and your ability to then function, and that's an important message to deliver as well. And the other thing is that exercise is a modern invention. 20 years ago, none of us knew what Facebook was. None of us knew what email was. None of us really knew what the internet was 20, 30 years ago, even 20 years ago. But that's something that we've had to learn in order to survive in today's society. Well, because of those things, exercise is also something that we have to learn in order to survive in today's society. So we need to address that for individuals. So the key thing is finding the balance, that there is a reduction in risk of disease if we're active and fit, but it's also challenging to deliver very intensive interventions of supervised exercise. So what we need to do is find where the balance point is with what you can do with the resources that you have. There is more support for supervised exercise, but not everybody has access to supervised exercise. So that's a key thing. So in summary, I'd like to say that, or to summarize my key points, that regular physical activity should be a consistent message by all healthcare providers at every visit. One of the top 3 things that you talk about, because then it becomes important to your patients. Exercise can give control over the situation and can foster a feeling of control and a feeling of health, because healthy people are active, whereas sick people take medicine. And so you can change a perspective in that regard by helping people to become more active. The other thing is that in helping people to be active, we need to bridge that awareness-action gap, that they may be aware that being more physically active is important, but we need to give them specific recommendations with information of how to take those steps. And in doing so, that they are relatively safe in doing so, that most people are at greater risk of continuing to be sedentary, where you're guaranteed to elevate your risk of chronic disease progression, whereas being active, you're reducing your risk. So the last thing is that we all have to think creatively about strategies to include more physical activity and exercise into every message that we give, into all of our programs, and into our facilities, into our healthcare facilities, into our diabetes care centers, and our community centers, to make physical activity and exercise an easier option than it is now. So with that, I'd like to open it up to some questions if there is.
Hey, Jonathan, I just want to ask you to turn off your lock talk while we're doing questions, so just use the control button on your keyboard to talk to us.
Yeah, I did that.
Okay, great. So does anyone have any questions? Yep. So the question is, who is funding the exercise that you're encouraging at the decks?
Well, we have been funded over the last 3 years by the Lawson Foundation. So in 2008, we got a 2-year grant, and then in 2010 got another 2-year grant that carries through to 2012 to basically disseminate the exercise toolkit in the first grant, and then subsequently in the second grant to disseminate it to all the Atlantic region, as well as provide enhanced services, being actual direct support for supervised exercise and referral for kinesiologists in Nova Scotia. So that's covered under this research. But what we have been doing all along is been encouraging and really trying to facilitate sustainable initiatives. So where we've been in the diabetes centers is saying, you know, how do you budget to include TheraBand into your yearly budget? How do you include exercise classes as part of your regular classes for your diabetes center? And how do you develop sustainable, community-based exercise programs that are kind of peer-led that can continue after you might facilitate something? So all along the way, we've been really trying to encourage sustainability, and you know, a partnership with the GFALD that we're now doing, as well as the partnership with now the Canadian Diabetes Association to disseminate the tool and to promote physical activity across the board, across the country, is beginning basically this week and again in the fall.
finding, I think probably others after this, is that one of the things we're looking to do is try to get partnerships developed with various community groups. We're trying to target especially age groups. And just because of the fairly high risk of diabetes in those communities. And the problem I find is just getting to the right people who make the decisions and getting them to actually make changes. Like I coach with one community that has a fairly large Middle Eastern population. And it's just a matter of just trying to get through all the red tape. And I'm wondering if you have any suggestions. Sometimes it just means you're dealing with people who are working in a community center. They may be the ones who pull the strings, but it's just, they need to talk about the budget, or just talk about that they don't really want to start anything right now, they don't have the resources, and you're paid for this. This is absolutely free. So it doesn't cost them anything, but they just have to basically get off your butt to, set the ball going.
Jonathan, did you hear that question? Because it's a mouthful.
Yeah, I was thinking it might have been easier to give him the microphone, but...
Thinking that, but he'd already started.
Yeah, maybe you could just synopsis. I got most of it, but if you could synopsis.
So getting through the red tape to get programs implemented in the community, do you have any suggestions?
Well, I do acknowledge that it is a challenge, and it requires a multi-pronged approach. I'm involved in another CIHR project right now that's actually looking at and trying to examine this brick wall that kind of occurs between referral from the healthcare system to the community, quote unquote, extended care system, and that there are very few programs that exist in communities that are dealing with chronic disease, and there's various reasons for that, and that the ones that are usually funded by specific research projects that kind of parachute in, do something, and then leave the hole in the community afterwards and say, yeah, this program was really effective, but now that there's no research funding, the program disappeared. So I completely acknowledge that this is a challenge. The Public Health Agency of Canada seems to fund certain projects to develop community initiatives. Most of them kind of are research slanted, and it would be nice if the provincial governments, federal governments actually carried through on kind of the platforms that they say that 1% of healthcare funding would go into prevention, which would include physical activity and exercise in communities to support these kinds of things, whereas it's always the first thing that's left off the map. So the key things that are important are partnerships. We're trying to develop partnerships with the Y, for example, with the GFALD program, with local recreation facilities to help train their instructors to be more cognizant and aware of the challenges for chronic disease. For example, for the Canadian Society for Exercise Physiology, we would love to have certified, instructors like our certified exercise physiologists, in these centers to help with that. Not saying that every single personal trainer in Canada needs to be a CEP, but meaning that, the more training that occurs in the community, the better. And, partnerships are important, advocating is important, and again, the initiative with the CDA to basically put physical activity and exercise on the map, so that then you have physicians groups lobbying for it, and it requires all levels. So the more that we talk about it, the better it is. I understand that there's red tape.
Thanks for that, Jonathan. We're going to take one more question, so make it a really good, fast one. Go ahead.
And one that I can...
The handbooks for older adults that can be guidebooks that we used to have and that are no longer available. Will we be having updated ones, and if so, when might they be available?
I think maybe that's a question that we'll address when we do our panel discussion tomorrow. We'll be talking about the new physical activity guidelines. We'll address the question at that time. Okay?
Actually, just to add to that.
Another question. Just because you have a nice red jacket on.
Exactly what do they look like, and do they include specific exercises, or is it just a pad where the doctor's going to write down, go up and exercise?
Did you get that, Jonathan?
I did. The actual prescription pad that physicians will do is going to be the prescription check off on the front. On the back is a little bit more how-to information on what to do, but it's brief. Now, the key thing, though, is I lobbied very, very hard to get how-to information on the back of the prescription pad, believe me. The key thing, though, is that there will be downloadable exercises. For example, the resistance training exercises are brochures 3 and 5 that go with the physical activity and exercise toolkit. Will be downloadable that do provide, 12 exercises for resistance exercise. So people can then go onto the web and get the further support as well as, video instruction of the different exercises. So that will be there. There will be more support for that specifically. And again, to address that previous question about the actual guides, they did meet last month actually to go through what the new guides are going to look like. So those materials will be coming out. It was important to get the actual new guidelines out before we had the guides ready to get the relevant science out as soon as we could. So.
Thank you very much, Jonathan, for joining us virtually. It was exciting, as it always is when we're working in the WIMBA classroom. So I thank you for your patience at the beginning, and hopefully everybody experience. You were cutting out a couple times, but it was good.
Thank you very much. It was a pleasure.
And one more thing, Jonathan, is it possible to post your email address up for those individuals in the room who had questions and didn't get a chance to ask them? We're just running into our lunchtime, and we don't want hungry people gathered together in this classroom. So if you could give us your email address so those people could send you an email, that would be fantastic. Thank you. And we'll also, for the people in the classroom, we'll post it on our website as well, so you can contact Jonathan with any other questions. And
yeah, it's pretty easy. It's just jonathan.fowles@acadiau.ca.
Okay, we're going to leave the WIMBA classroom now, Jonathan, so thank you very much. Bye.
You're welcome.